So we'll do our roll call. Let's see, do we have Senator Pete Goicoechea on?
Yes, I'm here.
Thank you, sir. Bryce Schultz? Jeri Sanders?
Yes, I'm here.
Thank you, ma'am. Matt Walker? I think I just heard Matt, huh? Sean Burt?
I am here.
Could you hear him okay?
Sean or Matt?
Yep, Sean Burke is here in Linda Buckland.
Oh, I hear you. Thank you, sir.
Hey, Matt's here. Sorry, I was on mute.
Thank you, Matt. Amanda?
I'm here.
Thank you, ma'am. All right, so we'll move to public comment. Is there any public comment? Alrighty, no public comment. Approval for board members by the Rural Regional Behavioral Health Policy Board. So we got, let's see. So Valerie, did I just go down the list here?
Yes.
Okay, so we got Fergus. Are we doing them one at a time?
That is up to you. We can either do all it kind of as a group or one at a time. I think that would be probably up to you and the other board members to decide how you want to handle that.
Does anybody have a preference?
I think
Are
a
you
group,
okay if we do?
group sounds good.
Group sounds good. Okay, so we'll just go ahead and list them off. And do I need the definition on here, Valerie, or can I just say the names?
Put their say their full name and the definition, the seat that they'll be holding. So you can just read off of it.
Just for the whole thing?
Yep.
Okay. I apologize if I screw up anybody's name. Oh, you guys are awesome. Thanks for being patient. Jeri, laughing at me. Okay, so we got Fergus. How do we say his last name?
Laughridge.
Laughridge. One member who is a health officer of a county or who holds a position with similar duties, or if no such person is available, an employee of a city, county, or Indian tribe who has experience in the field of public health. Dr. Erica, how do we say Erica's last name?
Ryst.
Ryst, thank you. One member who is a psychiatrist or a psychologist who holds the degree of doctor of psychology, has clinical experience, and is licensed to practice in the state, or if no such person is available, a provider of healthcare as defined by NRS 629.031, who has experience working with persons with mental illness or persons who have an alcohol or other substance use disorder. Brooke O'Byrne, one member who has received behavioral health services in the state, including without limitation services for substance use disorder, or a family member of such a person, or if such a person is not available, a person who represents the interests of behavioral health patients or the families of behavioral health patients. Steve Brotman, one member who represents the interests of community-based organizations which provide behavioral health services. Sarah Dearborn, one member who represents private or public insurers who offer coverage for behavioral health services, or if no such person is available, another person who has experience in the field of insurance or working with insurers. So all in favor? Are we going one at a time? Should we?
That's up to you guys.
Let's go one at a time. Senator?
Oh,
I make a motion that we approve those board members listed.
Thank you, sir.
I'll second it.
Thank you.
believe that would be an all in favor and then ask if there's any opposed.
All in favor? Any opposed?
Aye.
In favor here, aye.
Aye.
Any opposed?
Okay,
Motion
that's
approved.
okay, perfect. And just so that so Amy, you're off the hook. Fergus is on the call now.
Oh, thank God, Fergus. Thank you.
I'll let you go. You're doing a fine job. Let me shut my door.
Thanks for everybody's patience.
Okay, where are we at, Val?
All right, we are on agenda item 4, reappointment of Fergus Laughridge as chair of the Rural Regional Behavioral Health Policy Board. Also, heads up to board members, if you can please be sure, I was reminded by Joan from DPBH, who is going to be doing our minutes for us. We need to have our cameras on, or at least board members need to have their cameras on, if at all possible. Thank you.
Don't have the agenda up in front of me other than what's on the screen.
Okay, I'll scroll down. My apologies. Oh, and we also have a raised hand from our new board member, Sarah Dearborn.
Hi, everyone. I just wanted clarification because I'm new at all this. Since we were just voted in, am I able to vote along with you on today's meeting, or do I hold off till the following meeting?
Sarah, according to my understanding of Robert's Rules of Order, you are clear to vote and participate in the rest of the meeting. The only caveat to that would be the minutes for the March meeting, as you were not a board member or associated with the board at that time.
And for that, I would abstain, correct?
Yes.
Correct.
Okay, thank you.
Okay, item 4 is to reappointment of myself as chair. If anybody else wants to jump in there, feel free. Just need, if everybody's agreeing to have,
This is-
excuse my, pardon my voice. Go ahead, Brooke.
Hey, this is Brooke. I was just gonna move that we approve you as board chair for the next year or term.
This is
And,
Amy, and I'd second.
Thank you both. Okay, motion on the floor to approve Fergus Laughridge as chair of the Rural Regional Behavioral Health Policy Board. Rather than doing the all 4 and those against, I'll ask, are there any in opposition? Hearing none, motion passed unanimously. Item 5, review and approval of the minutes of the March 24th, 2021 meeting. Valerie, if you could go through those that were present. I don't have those meeting minutes in front of me. I've read them, but if you could read off who was present, so that way we know who's allowed to move the motion and to vote. And then those that were not, we'll just show them as abstaining.
Perfect. So members present as listed on the meeting minutes themselves: Senator Goicoechea, Bryce Shields, Matt Walker, Dr. Erica Ryst, Chair Fergus Laughridge, Brooke O'Byrne. I am listed here as a member. I am not a board member, so that might be one edit.
Okay. And did members have an opportunity to review the minutes? And if so, I would entertain a motion to approve as presented, or if there's any corrections.
It's Matt. I'll make a motion to approve.
I have a
This
motion on
is
the
Brooke. I will
floor,
second that.
and Brooke O'Byrne second. Again, those in opposition? Hearing none. It passes unanimously with those that were not in attendance show as abstaining. Okay, schedule of future meetings. Valerie, I'm going to let you lead off on that and where we're at. This is for scheduling of future meetings, correct?
Correct. Thank you, Fergus. All right, so what I have on the screen here is the proposed behavioral health or the Rural Regional Behavioral Health Policy Board meeting schedule through the end of 2023. The board has not had an opportunity to meet since, as you've seen, March 24th of last year. So there's a lot to catch up on. And I've had several requests for different topics as well as presentations. I did promise all the board members that I would try to keep the meeting short and sweet. So we may have to meet more frequently if that is okay, or if we would prefer to have longer meetings, that is up to you. So we have today's meeting, the 23rd, and then I would like to propose going monthly and hitting March 23rd and April 22nd. Thereafter, moving to a bi-monthly schedule through summer and fall. So June 22nd at 1, August 24th at 1 p.m., October 26th at 1 p.m., and November 16th at 1 p.m., and then getting another one in December. Because the BDR, I believe, is usually due sometime in December. So we want to make sure that we have an opportunity to discuss those topics as a board. Going into 2023, we move into the legislative session itself. So last session, we scheduled monthly meetings, so that seemed to work pretty well. So January 25th, February 22nd, March 22nd, April 26th, and May 24th. And then June 28th in case the session runs long. Then moving to a bi-monthly schedule again, August 23rd, October 25th, and December 20th. These meetings are all on, I believe, the fourth Wednesday of the month at 1 p.m. December 20th, I moved up a little bit so it wouldn't correspond with that time right between Christmas and New Year's. As well as this year moving the meeting to the 21st for the same reason. Some of the proposed topics that I've had either board members request or other stakeholders request to speak to the board about include we need to approve the annual report in March. And I have also been asked to include the potential for updates from the licensing boards that were affected by SB 44 in the March meeting. April 27th, asking for an update from the state regarding the launch of 988 and how that will affect rural Nevada. Also provider updates, including rural clinics, Nevada health centers, hospitals, Vitality, LifeQuest, Family Support Center, and any other providers that the board is interested in hearing from. There's always this opportunity to have more topics TBD. In June, we do need to set board bylaws, which would allow some of this coordination to go a lot more smoothly, such as making sure that there is a designee in case the board chair cannot make it. Also, we may have the opportunity to look and see if board members want to do proxies. If they cannot make a meeting, designating a proxy to vote for them, etc. We also need to start thinking about the legislative session and then any other topics. In August, more provider updates, that's the same list, and more legislative session preparation. October, looking at the comments and inviting comments from stakeholders who may be involved with the various BDR topics or topic that the board has decided upon. And then we're doing more work in preparation for the legislative session. November, BDR approval. And December is really kind of an optional if it's needed, at least it's on the calendar. And then going into 2023, that's a little bit more open, not really knowing yet what the future holds as far as legislative session and other topics that the board may be interested in at that time. So that is what I have for you at this time.
Any questions from the board members?
Fergus, this is Senator Goicoechea. Are we going to get into any kind of discussion as far as American Relief Act dollars or CARES money, you know, that pot full of federal money that seems to be floating around and, you know, accessing that or not?
Very good question. I'm not sure I've worried about what we're doing with our tribal money. I haven't worried about or looked at the state's coffers yet. Worthy to be noted, I would think. Valerie, could we plug that in for next month?
Absolutely.
Is that too soon?
That is absolutely fine. I think we want to probably work on who we want to speak on that behalf or on as far as those funds. Senator Goicoechea, do you have any recommendations, or Fergus?
Okay, time to go with this. Did you see that there's no time?
I do not. Pete, do you have any?
Didn't happen until July.
Is Joan trying to talk? Joan Hall, like it looked, he was kind of flashing there. I don't know if we're just not hearing her right. You know, clearly, there's a couple $2 billion in IFC that we're doling out by request. You know, again, I even sitting there, I really don't have a real feel for how this is going to work. But other than, you know, the money is available. You know, the governor and some of his staff do listening tours, but clearly there's some of this money should be available, and if we need some enhancements or what we need to have happen should be available. And again, whether the local jurisdiction reaches out on our behalf or, but I think it's something we're going to have to get into. And I know the governor delivered his State of the State today and talking about a lot of enhancement to programs. So, but behavioral health didn't seem to be part of it. So I think we're going to have to engage. And if there's somewhere, you know, again, I think we need to have the discussion at the next meeting, what it would really look like from this board, and as well as your expertise, whether it be, you know, Brooke or Joan, or, you know, you people really understand, and the local, Amanda, Jeri, you know what you need in your communities are. How can we address that? And you know, look at some money.
Yeah, I'd definitely be on board for that.
Excellent. Well, I will put that on the agenda for March, and I'll also see if I can get Stephanie Woodard or another representative from at least DPPH, DHHS to discuss funding streams coming down, including American Rescue Plan, and how that might affect behavioral health services. If anyone else has someone in mind that could be a potential speaker, please email me so that I can coordinate with them and make sure that they are on the agenda.
Senator Goicoechea,
This is Brooke. I don't
anybody? Sorry, go ahead.
Sorry, Fergus. I don't have much to add in terms of what to add to the agenda for our next meeting, but I will share that I know the Family Support Center in Winnemucca was in the first round of funding that came out from the community fund dollars. I think there were 4 agencies that were funded across the state, and they were one of 4. So it was nice to see behavioral health providers in our region selected. So I do know that little bit. That doesn't help for next meeting, but I'll share that in case you didn't know.
Great. Great. I was going to ask Senator Goicoechea if is there somebody within LCB that we might be able to reach to regarding the federal funds availability and some of the criteria to invite to a meeting?
Let me touch bases with Wayne Thorley, who's you know, head of fiscal there, and find out who'd be the best and what he feels would be the best way to, you know, get the most information out. Just like Brooke said, you know, I think it's trickling out in a dozen different directions right now, kind of piecemeal, typically through local governments and or communities. But, you know, I think if we could consolidate it, but let me reach out to him and find out who'd be the best, Fergus.
Okay. Yeah, and just share that with Valerie, if you would, please. Thank you. Okay. Any other comments regarding the meeting schedule for 22-23? Very robust. If not, entertain a motion to accept that meeting schedule, and we can get.
Tell it Patrick doesn't work.
Pardon me?
This is Matt. I'll make the motion.
This is Amanda. I'll second that motion.
Do you want to get closer?
Okay, that was that moved, motion by Matt and seconded by Amanda, I believe. Did I get that right? Okay. All right. Any opposed? Hearing none, passes unanimously. Thank you. Next item, Valerie.
All right, so I'm just going to give a very quick update as far as some of the things that I've been working on recently. I realize it's been approximately a year since you met, so but I think I've been in touch with most people during that time. One of the major projects that I was working on this fall and rolling into the beginning of the new year was an application for the DPBH Notice of Funding Opportunity for Behavioral Health, in conjunction with stakeholders across the 6-county region for the prevention category. The total ask was, I want to say ballpark, $750,000 over the 2 years. 100,000 of that was actually in vape detectors, which has been a request from several of the stakeholders that I've spoken to in recently, who work with youth. And so it would be, that piece of it would be purchasing the vape detectors and then distributing them among schools that are interested, as well as other youth serving agencies. So that could include Boys and Girls Club, juvenile detention, probation, etc. So anyone else who works with youth. Other parts of that grant include supporting school districts with SOS or other mental health crisis screening. We would also be hiring 2 community health workers and 2 LCSW interns for the work on this project. The LCSW interns would also be coordinating some of the clinical referrals as necessary through the screening processes as well. Also a series of town hall events for mostly held in either Elko or Winnemucca. Winnemucca seems to be really running with this idea. I know Elko is trying to get something on the calendar anyways, but if there's extra funds and we need to work with other communities, that's great. We have, I think, $24,000 per year set aside for that, so that we can get some good quality speakers and also do some communications to really get the word out as far as, you know, what the event and trying to get the general public involved. It will also pay for a great deal of training. One piece is train the trainers for mental health first aid, youth mental health first aid, safe talk and assist, so that we can get more community-based trainers within the communities here to just kind of reduce costs associated with getting those going. Another piece included setting up resiliency training for school-age youth, their families, and also school districts. I've been hearing a lot from anyone who's involved in the schools that school staff, including teachers, of course, are having a rough go of it in the last couple of years as well. And they're not necessarily getting all the support they need, and really being able to be there fully for a lot of the stuff that they have to deal with on a day-to-day basis. Of course, as you'll see later, and I'll have another updates, there's a youth mental health crisis across the country. Nevada is not immune, and certainly our region is not immune to that either. I actually heard this morning that there was a young man who was a high school student in Elko who committed suicide who died by suicide over the weekend. So the numbers for that we do have, although we don't have numbers across every community, are definitely startling. So looking at resiliency training to assist young people and their families in moving through this time of turmoil, shall we say. And I think there were some other pieces in there as well, including billboards for messaging, social media campaigns, etc. So I did talk to someone this morning about the timelines on that. I know that they were initially trying to let everyone know what was being funded and what wasn't by the end of this month, but it sounds like it might be the middle of March. So just a heads up. It might take a little bit longer, just because if you submitted an application and you haven't heard yet, that does not yet mean that you have not been funded. So we'll keep our fingers crossed that we're able to get some funding for that, as those pieces are all different things that the stakeholders have been mentioning to me for the last couple of years. I have also reached out to various law enforcement agencies regarding CIT and trying to get CIT up and running for them again. Currently in talks with everyone in Elko County, Eureka and White Pine regarding when they might want to do that. That's currently up in the air regarding scheduling, and we need to reach out to the actual training providers and see when they would be available really to be able to hammer that down, but likely either September or August. My counterpart, Jessica Flood, has taken on 3 interns, and myself, she and I and our new counterpart for the Southern Board, Kim Donahue, are sharing them. And the projects that we have them working on is really working on resource guide projects for the various entities kind of within the region, as well as working on the resource guide that is on the multi-board website. That is about complete. I do need to update our page with our new board members. So that's, I think, the biggest piece of the rural boards page that is not complete. Also general website updates, content development, and one ask that I had was the development of a telebehavioral health service listing. We do have multiple agencies that reach out to myself and my counterparts regarding what telebehavioral health services are available. And so we want to have something that we can hand them to be sure that we're not
income or in a neighborhood underserved by healthcare. Medicare Advantage has got your back. It's healthcare though.
Okay, there we go. All right, somebody's music was playing. We want to make sure that we're not really just leaning on one particular agency or company and playing favorites. So having something that's more like a menu to give to local providers would be a lot more realistic. I'm in discussions with Laura Yenes and intending to help them out with the NAMI Western Nevada strategic planning process. I've also been working on this multidisciplinary team concept. Aging and Disability Services is able to put together a multidisciplinary team to work on complex cases. I believe it's under Chapter 200 in NRS. And the way that persons with disabilities are defined there includes persons with mental health issues. So that being said, we were able to pilot some discussions in Humboldt County regarding a hyperutilizer and making sure that person got into more appropriate care and planning for when that person is discharged. And then also, I believe Judge Montero here in Humboldt County is also working on some sub-mental health crisis, sub-special courts type of processes. Something that I've been hearing from all of my stakeholders is that it's with the decriminalization of a lot of substance use, while we don't have people generating felonies for things that, culturally down the road may not necessarily seem like a big deal, it is creating a problem with getting people into care earlier. And instead, they are seeing from the law enforcement persons that I've been speaking to, a lot of people have been escalating through their substance misuse until they are committing more serious crimes. So trying to figure out how to best catch those people earlier on and get them into treatment in a way that is meaningful. I did reach out during my next presentation for the board priorities. I included some data from Safe Voice, which is a program that is offered by the Nevada Department of Education for teens to use to give tips regarding bullying, suicidal ideation, substance misuse, drug dealing, etc. And I will be presenting that data, but the data for Elko County specifically is really harrowing. So I just wanted to let you guys know the way that they do that, though, is there's like a threshold of 10 tips in order for that category to be included. And most counties didn't have enough tips in any category for that to be used. And I reached out to some of the Humboldt County people that I know involved with the schools, and they are advertising the tip line. So it's not something that hypothetically youth don't know about. Last week was the interim joint Health and Human Services meeting. Interesting meeting. I believe that was that last meeting, week before. Anyways, it was earlier this month. The focus was on substance use disorder, and there will be a lot of funding coming down, as Senator Goicoechea said, from not only the American Rescue Plan, but also from the opioid settlements. So I'm interested to see how that ends up playing out and how that gets to the local level. And hopefully we're able to get some more services here in rural Nevada where that is necessary. I think that's about it for the major projects. Does anyone have any questions for me?
Very good report, Valerie, as always, very busy in keeping the rural behavioral health issues at the forefront throughout the state. I'm really appreciative of that. With that, let's go into our priorities. And Valerie, I think you have a slide to bring up for that.
Death by PowerPoint, as always. All right. Perfect. Does everyone see that okay?
Yep.
All right, fantastic. All right, so just as we did last year, the plan here is I'm going to go over some of the available data and then also discuss some of the anecdotal information from stakeholders. Some of that you already heard from my presentation. And then we'll go over the board's priorities from 2021, and then from there build out the priorities for 2022. Oh, why isn't this working? There we go. All right. So data. Now, just for a baseline, a lot of this is just basic demographic data. This is for the entire region. DPBH, Office of Analytics, has started to group a lot of the data that is behavioral health related by behavioral health region instead of by county. That helps quite a bit with some of the thresholds for statistical analysis that I know that they've kind of struggled with in the past. And that way we make sure that we have data from our region and our region alone and not other regions that we cannot affect. Anywho, population of the region, just shy of 100,000. Our largest age group is the 25 to 34, followed by 15 to 14 and 5 to 14 and 15 to 24. I really want you to remember this proportion of the population as we get closer to discussing some of the trends that we see for overdose as well as mental health crises. So we're still a little bit more leaning towards a male heavy population. Much like in other years, the region is we can see that the region is 69% white non-Hispanic, followed by Hispanic, which is 22%, Native American, 5.5%, and then Black non-Hispanic at 1.6%, and Asian or Pacific Islander at 1.3%. When we look at drug-related deaths between 2018 and 2020, they actually dove down in 2019 and increased in 2020. When you see the number and age-adjusted rates per 100,000, of course, those numbers are really closely aligned because with just over or just under 100,000 people in the region, the number is going to be close to the rate. So just a heads up on that when we're looking at data in other tables. This is the age-adjusted rate, so per 100,000 of drug-related deaths by region. So this is how we compare to the other regions if the populations were all the same. So the good news is that the rural region is still lower than the others. But as we can see in 2020, not really by much. All right. So the tags that was given on the data that was sent to my counterparts and I had some interesting names. So this is mental related deaths. The next slide is actually suicide related deaths. So I'm not certain if the mental related deaths means the person was just not taking care of themselves, or what the issue may have been. But we can see this is broken down by race, still largely white, but it's disproportionately skewed towards persons of Hispanic culture or ethnicity. And then when we look at suicide related deaths, it's really skewed more towards, disproportionately towards Native Americans, as well as persons who are Hispanic, but even more so. Alcohol related deaths, again, we've got a disproportionate skew here. Now, the other thing to keep in mind here is this is per 100,000 of that racial population. So for example, here in 2018, there was not 135 people who identify as Black who died of alcohol related deaths in the region. There just aren't necessarily that many people. So if one person within that group dies, it raises that rate that much higher. So please be aware of that. Percentage of Nevada adults in rural behavioral health region who have seriously considered suicide. In 2019, that's the latest data that was presented to us, 6.1. I'm not certain if that is something that could be considered statistically significant from the previous year, but 2018 and 2019 seem to be much higher than the years previous to that. And that is even without the COVID fun and games. Percentage of Nevada adults in the region who experience poor mental health or physical health. Again, 2019, things were trending up. This gray 10 or more days is the most severe. And percentage of Nevada adults, so this is in the region, who use marijuana or hashish, illegal drugs, or painkillers to get high in the last 30 days. And then marijuana being the highest percent, followed by painkillers, and closely followed by illegal drugs. All right, so looking at female heavy drinkers within the region, still, I don't know if we can necessarily say there's a specific difference, but the rural region does tend to be higher than the rest of the state. Same with men. The blue is rural. And then when we're looking at binge drinkers, so this is people who instead of drinking large quantities on a regular basis or consistently on a daily basis, then drink large amounts a little bit less frequently. Again, women are higher than the other women in the state, and men in the region are higher than other men in the state. So percentages of Nevada adults considered heavy or binge drinkers. So this is statewide, not just the region. That does seem to be on the rise, and that is again pre-COVID. Nevada adults in the region, current tobacco, cigarette, or e-cigarette smokers. We don't have data for e-cigarettes apparently from 2019, or at least not that was given to me. It does look somewhat steady, but definitely higher in 18 and 19 than in previous years for tobacco. All right, so the state has this wonderful dashboard on methamphetamine and stimulant use for the state. And when I pulled up the data, this is essentially what we're looking at for methamphetamine use. I have heard from a lot of law enforcement that methamphetamine is on the rise. So I realized that this data itself, it said on the dashboard at the time, was last updated in November. I pulled this data down yesterday. Our region 10 looks like it tends to be a lot lower with the exception of Elko. And it looks like White Pine County and Humboldt, but still definitely a concern. And then this is prescription stimulants. I am not familiar enough with pharmacology to be able to articulate exactly what medications and prescriptions this may be, but we've got Elko ranks higher than the rest of the state, but Humboldt County, Lander County, and Eureka, White Pine, Pershing, while they are towards the bottom statewide, there's definitely still an issue there as well. suspected drug overdoses, and this is from the syndromic surveillance and prescription opioid rates. This is available from the overdose data to action program available at nevadaopioidresponse.org. The table on the left is from January of 2021 to June of 2021, and the table to the right is from July 2021 to December 2021. The reason why they're different sizes is the axes were actually a different proportion. So I tried to match them up so it would be a little bit more continuous. As you can see, when we're looking at drug overdoses related to opioids, and then the prescription rate is this skinny line up top. So for example, in November of 2021, the prescription rate went down, but overdoses still stayed higher than they were in September. October, from what I've heard from a lot of our stakeholders, was a rough month all the way around. And then May was also pretty bad, as well as December. Opioid-related overdose deaths by drug category. Now, this is the entire state. I could not find this data broken down specifically for the region, but I'd like to bring your attention down here to 2021. For example, with synthetic opioids, we have projected or preliminary number of 288 deaths statewide related to synthetic opioids, whereas in 2013, it was 25. That number has steadily grown since 2016. Methadone has reduced. Heroin, however, has also increased, but is lower than in 2019 and 2020. All right, so percentage of adults who rated their general health as poor or fair through 2019, that percentage has decreased, so that's not good. Percentage of Nevada adults in the region who experience difficulties because of physical, mental, or emotional conditions, higher in 2019 than in previous years. The blue is difficulty running errands, and the orange is difficulty in concentrating, remembering, or making decisions. Again, this is not affected by COVID. Percentage of adults who have a depressive diagnosis, and this is all Nevada. Pretty steady, but still a little higher than in 2019 than in 2018. And percentage of Nevada adults in the region who reported unfavorable mental health. So 2019 higher than 2018. The blue is depressive disorder diagnosis, and the orange is 10 or more days of poor mental health. So they may not actually have a diagnosis, or there may be something else going on, such as anxiety. But that is what that's looking like in our region so far. It looks somewhat undulating. However, as you can see in 2011, that was still super high as the state was coming out of the recession. Percentages of Nevada adults whose mental health was not good by days affected. That increased in 2019 as far as those with 10 or more days. And then I was able to get some really great data from Northeastern Nevada Regional Hospital for the patients that they see. I have been working with some of the other hospitals to try to get similar data. But this is what they've been able to give us so far. So orange is female, blue is male, and this is the number of patients they saw in their emergency department who presented with suicidal ideation by sex. And when we're looking at these totals, in 2019, there was 149, in 2020, there was 179, and in 2021, 231. So while there was a 30% increase between 2019 and 2020, there was approximately just over 50 people that they saw a difference between 2020 and 2021. I believe with those numbers, that would actually probably be statistically significant, but I have not run the tests. When we look at that same data by age group, almost a third of those patients were under the age of 18. And as you saw by our population statistics, looking at the entire region, that age group does not make up a third of the population of the region. So we're looking at young adults being disproportionately affected by mental illness and particularly crisis. Again, I do not have this data from the other rural hospitals. The ones that I have spoken to have not seen quite the increases in youth suicidality in their ED that has been seen in Elko. There's potential for a lot of different reasons for that. Other communities may have more resources set up in schools. I know that the Department of Education is trying to work with Elko School District to kind of improve some of the connections and services they have there. But it does seem like there is something going on in Elko specifically. When we're looking at number of overdoses, again by sex, increased by 40 people between 2020 and 2021, while the numbers were pretty steady between 2019 and 2020. And then when we look at that by age group, the 0 to 9 tends to be, from speaking to their doctors, tends to be more accidental overdoses with over-the-counter prescriptions or not prescriptions, over-the-counter drugs such as acetaminophen, ibuprofen, that sort of thing, or medications that are left around. And it's when you get into that 10 to 14 and 15 to 24 age groups that it's actually more opioid related and less accidental. And this is that Safe Voice data that I was talking about previously. And the red is suicide threats. And the green is handle with care, which I believe is just concern about other persons. And so when we're looking at suicide threats, it was fairly consistent through 2019 and 2020 from 20 tips to 26, and then skyrocketed to 91 in 2021. Unfortunately, I do not have any information as to whether or not that was multiple people sending in tips about the same person, or one person sending in multiple tips about themselves, or what the deal might have been. So a little bit of caution there, but still definitely something for concern. From the other counties in the region, Eureka, all the tips were under 10. Humboldt County in 2019 had 13 tips total about bullying, and that was it. Lander in 2020 and 2021, we had 13 handle with care notifications, and then all the other tips were under 10. Pershing and White Pine also, everything was under 10. So not seeing a lot of traffic to that specific line from those other counties. So whether that means that there isn't as much of a problem or the students aren't using it, we can't really be sure, but it's somewhat less alarming. And then when we're looking at the Rural Children's Mobile Crisis Team calls and responses for rural clinics, this is all rural counties. So this is not just our rural region. So just kind of be aware of that. The diversion rate was pretty high, and the total call numbers throughout 2021 stayed pretty stable. In May, there was it looks like a spike to 42, but in September, 55. So there we have the end of the school year and the beginning of the following school year. So from the stakeholders I've spoken to who work a lot with youth, that tends to be a time when there is a lot more stress and a lot more issues that bubble up. I promise I'm almost done, guys. So takeaways: youth mental health is a major concern, and we can really more prove that is an issue in Elko County. Adult binge drinking and heavy drinking remains higher in the rural region than the rest of the state. Alcohol abuse and substance use disorder is still on the rise in most counties. Youth overdose and substance misuse remains an issue across the region. And then this is from what I've been hearing from our local stakeholders. So hearing a lot more about an increase in patients within the last, I want to say 3 or 4 months, presenting to the emergency department with mental health crisis. A lot more patients coming in with alcohol or substance use issues, increased depression and suicidality among youth. That shouldn't be a surprise at this point after seeing that data. Increased intentional overdoses, particularly in youth. So for example, one story I heard was that there were 2 13-year-olds who got their hands on some prescriptions that were not prescribed to them. And one kid took it in front of his friends, overdosed, and the one friend watched this happen. 2 hours later, the other kid took the same pills and also overdosed. So given that he watched his friend overdose with the same amount, likely an intentional. Acute difficulty accessing inpatient services. So because of COVID and the COVID outbreaks in the inpatient facilities, it has been nearly impossible for anyone to get people into inpatient services. Working with the hospital here, I know that they were actually able to get a person who was COVID positive into treatment faster than they were able to get someone who was COVID negative, just because of the rampant COVID across all these facilities. Increased waiting lists for all types of treatment. At the beginning of 2020, a lot of the wait lists for treatments decreased in length. However, I'm hearing that things are back up to at least a couple months for a lot of different types of outpatient treatments. Drug decriminalization has been an issue that I've heard from law enforcement, in the fact that it's making it difficult for them to work with their DA, again, getting people into treatment courts before things escalate. So that's kind of what I was talking about in my other presentation. There's also some concerns over Suboxone misuse that I'm hearing. So I have been speaking with Track B about that, but essentially the misuse of Suboxone as a sort of trade or currency among inmates in jails where that may be available to them, and in the streets. And when we're talking about persons who, $15 may be the difference between making it that week or not, selling a Suboxone may seem like a good idea to them at that time. And then methamphetamine use being on the rise is another thing I've been hearing consistently from stakeholders. Last but not least, fentanyl being a growing concern across many counties, largely in the communities that are on our interstates. So just because of they're on drug trafficking routes. So with that, moving on, these are the board's priorities from 2021. There was an increased accessibility of transportation to crisis and non-crisis behavioral health services, increased Medicaid or CMS reimbursement for behavioral health services, improving behavioral health workforce development, so getting more providers and more high quality providers, improved behavioral health data quality, increased interagency communication and partnership, improved access to appropriate youth, elder, and minority services, and last but not least, improved quality and accessibility of services for service members, veterans, and their families. So with that, I would like to open it up for questions from the board regarding any of the data, ideas, thoughts, or anything else.
Sean Burke here from Lander County EMS. So I think those are great set of priorities. I didn't see anything on there that I think should be decreased by any stretch.
Thank you, Sean. Could everyone hear Sean okay?
No.
No.
Okay. Sean, you want to scoot a little, I'm sorry.
Yeah, Sean Burke from Lander County EMS. And looking at that priority list, that seemed like a great list to me. I didn't see anything on there that should be decreased for sure.
Awesome. Thank you, Sean.
Valerie, could you toggle back to the 21 priorities? There you go. Just so folks have those up in front of them.
Sorry.
So for those new to the board, we were able to tackle quite a bit of these to some extent, and not fully correct last session and through last couple of years. So be mindful of that. But we worked on workforce development with the licensing board. We'll hear more from them. Valerie continues to work with the crisis services. We've had conversations with Medicaid with respect to behavioral health. So keeping that in mind, let's look at what do you think we as a policy board would want to tackle going into 22? What seems to resonate in your in your communities, your professions, your everyday life that with respect to behavioral health. Keeping in mind that this is a policy board that we try to move those issues forward to the forefront for our legislative body. We're blessed to have Senator Goicoechea that's been actively engaged with our group for some time since its fruition. And we also are able to draft a bill draft going into this session if there's something that we really need to bring to light. So giving that, I'd like to open it up for discussion.
Hey, this is Matt. A couple things kind of strike me. One, the issues that were 2021, I think still exist. I think it's great. Some of the changes that were made with the licensing boards, and hopefully that will help. But I think behavioral health workforce is still an issue. And if you fix that, you fix 2 or 3 of the other ones that are already on there. So I think probably a focus on workforce, whether it's increased loan repayment or in rural areas or, whatever, we could probably get creative. The other thing is transportation, still a big issue. Last year, we decided not to really, or 2 years ago, whenever it was, we didn't push that one too hard just because there was no funding. So my thought is now that there potentially could be some funding with various grants and CARES Act and everything else, that might be one that we maybe look at again, assuming we could find funding for it.
Good points. Thank you, Matt.
I agree with Matt. We have the same problem in Eureka. The same issues that he has in Ely, we have in Eureka. He has a little bit broader span than we do. But the workforce in the transportation and the quality and accessibility to services. So he's right. If we can get the workforce up, I believe that would knock quite a bit of it out.
Okay.
This is Brooke. I'll kind of echo what has been said already in that workforce development, I think, is still a huge issue. I'm still hearing about a lot of challenges getting people licensed who have the education but don't have, essentially they'll have to relocate to finish their license. And that's problematic to me. And then, we already have youth services on the list, but obviously the data that you shared, Valerie, just emphasizes the need for us to focus some attention on that population even more, especially as, I know schools are completely overburdened with trying to respond to that among many other things. So for me, those are the 2 biggest priorities.
And I think Valerie will try to capture this and work at the syntax of putting this into a working document. So feel free, spew it out there. Let's do what we got.
Hey, Fergus, this is Erica Ryst. Are you able to hear me?
We can, Erica.
Okay, wonderful. Sorry, I was late. I had a doctor's appointment that went really late, so I missed a bunch of stuff. But for me as a child psychiatrist, a lot of the data that Brooke was presenting around increased overdose rates in youth, it really dovetails with our national youth mental health crisis. I'm sure you're all aware that a number of different child serving organizations, including the American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and I think the Children's Hospital Association has declared a national emergency in children's mental health. So we're going to see that in our populations, and the more that we can prioritize that, the better. And then the other thing, I don't know if you guys already discussed this or not, but in Reno, we have a crisis in terms of psychiatry hospital beds. So West Hills Hospital closed a few months ago, And we still have Reno Behavioral Health. We've got Carson Tahoe Hospital, but that was a huge number of psychiatry beds that we lost, which I'm sure will affect the rurals as well. And then for youth, it's even worse because we currently have no psychiatric beds in Northern Nevada for youth under the age of 12. And then apparently RBH will only take adolescent females. So basically boys under the age of 18, we don't really have a place to send them if they have psychiatric crises. So that's a huge issue.
Yeah, the bed availability is a big issue. Within the rural region, I was just at a meeting last week in Lander County, and hearing from Elko sending folks out of state, even to the local air provider doing transports of folks needing services in-state and out-of-state, transferring to Southern Nevada and to Salt Lake and Boise. So it's a big issue.
So, I mean, maybe Valerie could look into some of the data as to why we don't have more beds in Nevada. I mean, the workforce is at reimbursement. My guess is reimbursement is probably a big part of it. But maybe we should look and see what's causing the problem.
Thank you. Yeah, that's a good point, Matt. And then with the reimbursement side, Sarah Dearborn, who is one of our new board members, is actually with Nevada Medicaid over behavioral health services. So Sarah, I don't know if you have any insight on that.
Well, that's always a hot topic for sure, for people to increase the rates. And I think that kind of goes along with workforce development, just as a informational piece. We're definitely seeing some more rate appeals from the residential treatment center level of care, so also known as psychiatric residential treatment centers. We're hoping that with rate appeals, we're also going to see more access to those types of beds when needed as well. In some of our recent rate appeals that have gone through, we're still seeing that there's a lot of open beds. So that could correspond with that workforce development piece and just not enough behavioral health staff to support the amount of beds that are in some of those facilities. So that's just one piece, but I'm happy to provide any insight into the processes for getting reimbursement rates increase. Of course, it kind of goes along with legislation. So it sounds like this is a great avenue to maybe support a BDR to bring to the legislature to support that for sure. I know there's some work being done with our rates unit under AB 108. I can't remember the session it was from, but it was from long ago, where they review different provider types and kind of compare among other states the different rates for other behavioral health services. So I think recently they did a rate review for some of the behavioral health provider types. I believe that report is posted on our website as well. So that might help provide some insight for all of us as well.
Thank you, Sarah. So what I'm hearing is that instead of having maybe all of the priorities listed in kind of a non-priority manner, maybe putting workforce development in transportation as well as youth services as kind of like the three major priorities, and then youth, family, minority services, or maybe even just breaking out youth services separately. And then kind of looking at access to care for the other pieces that we have here. What are your thoughts on that concept?
Makes sense. I think they all kind of go hand in hand though. I mean, if you have more workforce, you're going to be able to help the youth and the minorities and the vets and I mean, you're going to probably hit most of those areas anyway.
Okay. And Sean just mentioned that we do have, Medicaid reimbursement on there too. So maybe we have kind of a multi-tier. Okay. Are there any pieces in this that you want to remove, or is there anything that you would like to add from the board priorities?
What of mine, Valerie, this is Fergus, comes to mind is looking at community programs and aged focused programs. So combining the two and maybe increasing the accessibility or delivery of aged focused community programs. I'd like this to get to the grassroots effort in individual communities or counties, because what works in Elko might be slightly different than what's needed in a Humboldt or a Pershing or somewhere else. Just that for consideration. Then I think we still struggle with I don't know how to phrase this other than to just say we struggle with public perception of behavioral health and recognizing, so there's still a stigma of around behavioral health, and how do we educate the public on what is the prevalence, education on the prevalence of the behavioral health crisis in Nevada.
Okay, so maybe including stigma reduction for behavioral health as one of maybe like if I was divided into 3 tiers, maybe that would be with tier 1 being at the top and the most important. Maybe that would be like a tier 3 or a tier 2. What do you think of that? Okay.
I've got another one too. Sorry, I'm talking so much. It's Matt again. I am curious, the inpatient bed issue, like that's a huge issue because in rural, we have, well, probably everywhere, not just rural, but you get the patient in your ER and then no one will take them because there's either all the beds are full or there are no beds. So they're not getting proper care and they sit in the ER for days or weeks sometimes. And it's not fair to the patient. And it's kind of rough on staff because it's not really set up for that, right? But I guess what I'm wondering is if we could try to figure out why we don't have more inpatient beds, it would help everyone, not just rural, but urban as well. And I'm just curious, like, is it because it's so hard to meet regulations that the state has in place, or is it just I don't know, I just think inpatient beds might be a good one to put on there. Like, I know access is on there and it's kind of the same idea, but specifically inpatient beds.
Okay. Do we want to put that as like a tier 1 or a tier 2?
I don't know what people think. I don't know if anyone agrees with me, but I think it's an issue. I also have noticed, like, we'll send someone out, they're there for 12 hours and then they get discharged, but they get back here and they're no better than they were. But it's because they got them through the real bad part and they were able to get quote unquote safely discharged. And it's because they don't have enough beds, so they're trying to kick people in and out as fast as they can. But I don't think they're really doing any favors to the patient.
So continuity of care through the levels, essentially, of need, is that so?
Yeah, I think that would be part of it too.
Yeah.
Yeah, Valerie, I think that's fair to say for Elko County too. As Fergus mentioned earlier, we do send a lot of our psychiatric or mental health patients to Vegas and or to Boise or Salt Lake, but we're seeing them back within 24 to 72 hours, even being life flighted out of here or flown out.
Okay.
Yeah, we identified that there's an issue. We identify that there's a lack of beds, but what are the barriers to expanding the capacity? I don't know that we've ever really delved into that. Could be multidisciplinary, but that goes to what Matt's saying. Why is it that we have this shortage?
Well, from what I've heard from the last Commission of Behavioral Health meeting that I was on the call for, it comes down largely to workforce, but also in pay. So particularly for NAMs and SNAMs that are run by public agencies, and the salaries are capped, kind of what Sarah was alluding to previously, and would require a legislative fix. So for example, one participant on that call was mentioning that the salary for, or the hourly wage for a admin or assistant of some sort in one of those facilities is $11 an hour. Last time I went to Burger King, I drove by and they were hiring at $14 an hour and still couldn't get people. So I can see how people might prefer to go work in fast food over being in an inpatient mental health facility, unless that was something that they were passionate about. So that is definitely a concern as well.
This is Dr. Ryst. In addition, I mean, right now the real crisis is lack of beds, but even prior to that, there were issues with quality of care. As I'm hearing people talking about really severely mentally ill patients getting discharged within 12 to 24 hours, I mean, that's not quality care. So I think it's been a domino effect. I'm not sure of all the exact reasons why West Hills Hospital closed, but hearing through the grapevine, I think there were some quality of care issues that actually contributed to them closing. So I think we should keep that in mind too. It's not just the number of beds, but it's the quality of care that's provided in the hospitals.
Excellent. That's a great point. And something that I've been hearing too is that it's really also those mid-levels of care where they're not ready for outpatient on a weekly or monthly basis, but really more intensive outpatient, if outpatient at all.
Absolutely. And that's something that's more transportable. I mean, we could have intensive outpatient programs that are, located in rural areas, and that way people could stay in their communities.
Okay.
This is Brooke. Kind of tied to all that, my experience has been, or one of the bigger challenges that I've noticed is that transitioning care. So when you have, for any of us, whether we're sending people to Vegas or Reno or Carson or out of state, and then they do end up back, whether they stay longer or they're back within 72 hours, there's still that continuity of care and care transition that has never been there for, I can't really think of any cases where there's been great planning. And so bed access has always been an issue. And for me, because the quality of care and the quality of transition planning has been so poor, I don't put it high on the list, just because it's right, we're not even helping people get good services. So that's not to say it's not, I mean, we need beds. We don't have enough. We've never had enough. And then, I mean, this all ties back to the transportation issue, because how many times do you find a bed and somebody's like, yeah, if you can get them here in 5 hours. It's like, oh, okay. So as Matt has said, it's all very tied together, but I think that mid-tier of services and care transition is huge in my mind if we're going to focus on beds.
So Valerie, could you talk with, I don't know if it's administrators or whoever runs these facilities that currently exist in Nevada, and see what they say their stumbling blocks are? Because like you mentioned, getting information, like when we had Ely Mental Health, a state-run mental health agency here, behavioral health here in Ely, they would not share their records with us no matter what we did because it was quote unquote a HIPAA violation. And it's like, well, our doctor's the one that's providing the medication, our LCSW is doing the follow-up. If we don't have your records at all, then how are we supposed to do any kind of continuity of care? So I just don't know. I mean, is that a thing? Is that why they're not reaching back out to us to tell us what to do because they don't think they're allowed to? Or I don't know. I would just be curious to see what they say. Or do they, and also do they not want to expand because regulations are so ridiculous? Or I would just be curious to see what they say the problems are.
Absolutely. So I will do that. And then just kind of a quick note. So we've been having discussions about this across the region. Here's a part of the problem. So you have open beds, which is essentially a referral program. It's not just for inpatient, but also for outpatient as well. So Brooke, to what you were saying about, hey, get here in 5 hours or it's gone. Luckily, my understanding is that that is no longer the case. Essentially, when you assign someone a bed through that portal, let's say if you are at Battle Mountain General, you're using open beds, you link someone to an inpatient facility in Reno, that is their bed.
Is that a mandatory thing they have to use to arrange that?
They're trying to make it mandatory,
I was gonna say,
sort of.
because that 5-hour window thing was a thing like 2 days ago.
Yeah. I believe it. Yeah. So they're trying to use that more and more when you go do, I mean, the history of behavioral health is for most part, you have people's cell phones and you know a specific person at an agency and you call them or text them, say, hey, I need to get this person in there. And they say, okay, we got an open bed, but yeah, get here. Whereas hypothetically through this platform, that bed would be designated for that person and it's on record for that individual.
I just don't think that's
Yeah.
well known or used because yeah, I mean the extensive wait times is definitely common. You know, we have people in our ER for 3-4 days at a time before we can get them out. And then yeah, it's definitely get them here in 4 or 5 hours or you lose the bed.
Yeah. So I don't know if everyone could hear Sean okay. Okay. I'm getting a couple head shakes. So Sean mentioned that was in his field of practice and his experience, that was still very much his experience, that it was that, get here in five hours or else it's gone sort of thing still. So that is clearly something that we need to work on. Yeah, the sharing of information piece, the other part of that is having a health information exchange, and there is a Nevada Health Information Exchange. It was launched as, I think they launched it under a nonprofit. Unfortunately, it costs providers, from what I understand, it costs providers like $50,000 to participate. So if you are a clinician who has your own shop, you probably don't have $50,000 to spend on that. And I know that is a lot of money even for our rural hospitals as well. So there is another organization that I was just speaking to called Unite Nevada. It's part of Unite Us, and they're essentially trying to be like a referral platform for social services and case management. It is more social services oriented, but I think there's a health component as well. It is, I believe, a private company or organization, so there might be a cost associated with it, but they said that for nonprofits, it's free. And then that I'm hoping or wondering if that would include nonprofit hospitals. So I can reach out to them as well and see if that's something that could be utilized. Oh, yeah. All right. Okay, so as our kind of top tier priorities would be transportation, behavioral health workforce development, and then increased capacity for higher level care and continuity of care. So inpatient, intensive outpatient, and that sort of thing, followed by Medicaid CMS reimbursement, or do we want to keep that high, like have the 4? Anybody? Matt, I think.
Sorry, if I were to guess, I would say the reimbursement probably is going to go with the number of beds. I mean, I think it's going to be one and the same. Like, why don't we have beds? Because we don't get reimbursed, probably, right? Or something like that.
Okay, so I'll put those 4 side by side as kind of a continuity. And then second tier down, probably, oh no, you still have youth care. All right, well, I will wordsmith this.
Valerie, is telehealth follow-up a component somewhere that's nested inside here? Is that, you know, in transportation or accessibility, is that somewhere in there?
Okay, and so for anyone who might not have heard Sean, because apparently people are having a difficult time, he asked if telebehavioral health follow-up was somewhere nested within these existing the priorities. There are services for that. So the Nevada Care, the Nevada Care Team, which is the adult mobile, but it's really telebehavioral health crisis team, does do follow-up post transition from inpatient, outpatient, et cetera. They also handle crises via telebehavioral health. Also, NAMI Western Nevada has a caring contacts program to which, and it is on open beds, to which providers can refer patients. So they will call people at regular intervals, whatever that specified interval will be, and just check in on them. Because it is NAMI, it is, I believe, a peer program. So that person, the person who is doing that contact will be a peer who has, you know, been through whatever that person has been through or something similar.
Well, that seems like a good way to leverage, you know, technology. You know, the thought that we're going to get a bunch more people doing, you know, follow-on stuff, you know, in that workforce development category, probably not going to happen. So if there's a way to leverage that, you know, into the priorities, I think, you know, that would be helpful, at least in Lander County, where it's super rural.
Absolutely. Okay.
Sorry, this is Matt again. On the telehealth line, do you know, can someone who gets their master's in social work and they have to have a certain number of hours under someone, can they do that via telehealth? Like, could you see patients here and have someone oversee you or vice versa? Does that make sense?
That does make sense. So you're asking if they can do that within their internship?
Yeah, to get their license so that they can actually practice on their own. Can they do it from rural where telemed?
Yeah, I will need to look into that, but I believe they can.
I don't think so. Sorry to jump in here. This is Brooke. If I understand correctly, this is part of what some of the folks in Winnemucca are struggling with, because they have 2 candidates and they can't figure out how to get the hours completed because they can't do it remote.
So that's
like they need a physical on-site supervisor. And again, I'm getting this secondhand, so I could be misunderstanding the issue, but I don't think you can have kind of like a remote revision piece like that.
And that's something we tried to address in the SB 44. And I reached out to the Board of Social Work because all the regulations for the different licensing boards needed to, or essentially it was mandated that they needed to fix their regulations to make it possible for someone to live in rural Nevada and be completely supervised remotely. However, it sounds like from my conversations with the Board of Social Work, they are going to be working on those regulations later this year. So maybe that would be a great opportunity to ask those questions of Karen Oppenlander, who is their executive director, at our next meeting when we do have the licensing boards present, because hypothetically that shouldn't be a problem, but we'll see. Yeah, my understanding with here in Humboldt County, they're needing 2 supervisors. So one, which is their main supervisor, which is offsite, but then they have to have someone on site to also provide supervision, which is the same problem as if everything had to be on site. So that's definitely a problem. And then Matt, your audio was a little fuzzy. So I'm sorry if I haven't been directly answering your question, but I believe when you were talking about whether or not that student intern can complete their hours while they are doing telebehavioral health, I think they can, but it might only be a certain percentage.
Thanks.
Okay. All right. Okay. So I will splice out. All right, so essentially we're going to keep most of these as they are. I'm going to drop down behavioral health data quality and military services and increase interagency communication and partnership down to a lower tier, essentially. And then also put that stigma reduction in probably a second or third tier. Does that sound like a good addition and essentially change here? And then we'll be adding in something along the lines of quick connection to inpatient, to high quality inpatient care and continuity of care across appropriate levels. Is that what we're looking for? Sean's nodding.
Yep, I think you got it, well.
Okay, cool. So that being said, Fergus, I think it's up to you if we want to vote on that or not.
Yeah, I think we have the core understanding. We've had the discussion. So now we've heard the recap from Valerie. If we're in favor of that, I would like to move this forward with and then she can wordsmith it and get the fine, color tuning and all that done for us in the background. So I would definitely entertain a motion for that. Oh, wait a minute. Can someone repeat the question? Okay, there was a comment or something popped up in the chat there.
Oh, so Karen, this is from Karen Oppenlander. She is the executive director of the Board of Social Work. So the questions, so Karen, the questions are, can social work interns provide services via telebehavioral health? And when can we look forward to interns being able to access completely remote supervision? I think are going to be the major questions there.
And if they can't, what are the barriers to them not being with telehealth, telemedicine being what it is and how it's progressed through the COVID and the public health emergency? Why is there a barrier to us using that going forward? And we'd like to have some discussion on that.
Okay, excellent. We'll do, and we'll make sure that the other licensing boards are posed the same questions as far as what their interns can and cannot do.
Yep. Okay, so on the priorities, we've heard the discussion. I would entertain a motion to accept those, and with the caveat that Valerie will fine tune the wordsmithing in the color graphics that go with it.
So moved, Fergus.
That was Sean. Sean Burke makes the motion. Second, anybody?
Second.
This is Brooke. I'll second that.
Brooke and
Jeri.
Jeri, second. Again, going this because we have so many folks. Anyone opposed or have comment? Hearing none, passes unanimously. And Valerie, you got your work cut out. Thank you, folks.
Right.
Next is item number, let's see, where are we at? 9. If folks, in the interest of time, would like to share what's going on in your areas. But before I turn it over to everyone, I just want to, because I was not able to be on earlier, dealing with some issues here at my clinic. Wanted to welcome the new members, those that returned and want to be subjected to being part of this board continually. Your work and your input, while these meetings can sometimes get long, is definitely invaluable to us and to what we're doing and trying to make change within the state. And we've been able to do that through some of the activities with the licensing board. And as you know, your charge is that we speak for the people out there, and we are given the opportunity to craft and work on legislation to make change. And so just keep that in your thoughts as we navigate through these over the months ahead, and be engaged. Valerie is still always available. We're blessed to have her as our support to help us through these things. So we have as you can see by looking at the previous item there, and I think Valerie will put out a little worksheet, or a little one pager, or maybe it's a two pager now, with as we grow, of people's names and what your backgrounds are and who you're representing. And you will see we're a very diverse group that we can affect change. And I just want to extend my thanks to all of you that have been either volunteered or voluntold to be a part of this board going forward. So thank you. And with that, I'll turn it over and jump in there wherever you want with roundtable discussion from the board members.
Yeah, Fergus, Sean here. I'll go first. Very excited to be on the board, and also excited to hear that the transportation is an issue that is going to get addressed. You know, that's directly in my lane in EMS, and an area that doesn't get much play. So I think the ability to put some additional light and resources towards that, I think, will be immensely beneficial. Just regarding the things we're focused on at Lander County and at Battle Mountain General Hospital, that the issue with substance abuse, we run about 120 calls a month, not a very large service, but I don't think it's an exaggeration to say 25% of those are behavioral health related, especially with regards to substance abuse. Alcohol is still the substance of choice in Battle Mountain and surrounding areas, but meth is really prevalent as well. So trying to deal with those issues, that's pretty much what takes up our time. So thank you.
Thanks, John.
Thanks, John. Anybody else?
This is Brooke. I don't have too much more to share, but one of the things I did want to kind of ask from everybody else as we prepare for future meetings is, I think for me, as we think about the next session, it would be really helpful to hear more from other communities about how our past work has supported them and what challenges and barriers they're still experiencing. So as we try to turn some of these priorities into a BDR for the next session, we're really dialing into something that could have the biggest effect of change for our region. So kind of keep that in the back of your mind, because I don't always hear what's happening everywhere. So that would be helpful for me.
Good. I think Jeri was going to have to drop off. She has to set up for court. I think she dropped off already. Okay.
Well, I thought I'd at least introduce myself. And I want to say thank you very much to Valerie and this board for appointing and approving me to be a part of this. It's really an honor to be a part of this distinguished board. Just hearing the spirited discussions today, I'm very excited for the work that we're going to do together. And I'm really kind of in the same sort of view of where some of our efforts need to be pointed, particularly in the areas of workplace development and really recruitment efforts of getting the right properly trained folks into some of these rural areas where there's a paucity of these services and activities. So I'm really glad to be here. Thank you so much for allowing me to be part of this. Thank you.
Hey, Stephen, where do you work?
I work for Nevada Health Centers, and we are in the process right now of developing a Elko-based behavioral health center, which we are really excited for. And there's gonna be a lot of recruitment and a lot of workplace development opportunities there. So I'm sure I'll have a lot of love to solicit a lot of feedback from the members of this board.
Excellent. Thank you. Any other?
This is Sarah Dearborn, and I echo Stephen's sentiment as being honored to be part of this board. This is my first meeting, so I don't know how much communication you've had from Nevada Medicaid kind of on what is going on in the behavioral health unit. I'm wondering if it might be helpful for me to provide just an overall update. It's not just one target area, it's kind of encompasses all of behavioral health services. So I'm wondering if maybe at the next meeting, if you'd like me to provide more of an update. We have Nevada Medicaid has 2 planning grants that are underway, one related to mobile crisis services, and then one in regard to the Support Act. We've actually been awarded the 2nd phase of the Support Act planning grant, which we did a lot of awesome work in about for a year and a half. And now this phase of it is about 3 years long. So we have a lot of work to do under that grant as well. So I'm not sure if it's appropriate to put those together under this agenda item, if there would need to be a different agenda item for that. I don't want to take up everyone's time, so.
Yeah, no, Sarah, I think that'd be great. I think we can, Valerie, we can get that plugged into one of our days where we have time set aside for that, so that we can really focus truly on, you'll find that the focus is better at the front end of the meeting than it is at the tail end when you're like item 9 and 12 is adjournment. So
Yeah.
we just want to make it right for you. And I think the information will be great for everybody.
I think so too. And I mean, just listening to everyone talk, there's a lot of pieces that Medicaid is working on here and there that touches it all. So I think it would be really helpful for everyone just to have awareness of what Medicaid, what the Medicaid benefits are currently, what we're working on, and then what we can expand on in the future as well. So, and I know it's Medicaid, so it's confusing. So if you want me at the beginning, that's fine too, when we're all fresh.
Very good. Thank you.
Mhm.
Any others? Good of the order, as we call it?
Fergus, this is Senator Goicoechea. Just going down the road, I'd kind of, doesn't have to be the next meeting, but at some point, really, we need to address what the state is providing. I mean, what beds are available? Where do you go, Brooke or Shane or Matt, when you're trying to send somebody, move somebody out of your community? And again, whether it's mental health or drug related, what is available? How do you get them there? And really, what is the state providing us? We need to have those numbers and what is available to rural Nevada.
Good point. I think the resource guide that Valerie and her counterparts are working on will help to some of that, but there's more. And I think, and I hear what you're saying, Senator, it's the more part that we need to identify, and or where that gap is, and because a lot of this work is being done, as you well know, in your district, that it's being done at the frontline level, and it doesn't get to that other level. Maybe get pushed down from there, or barriers get put in place. We've seen that with some of the boards and things that we've worked with. Barriers, maybe it wasn't the intent, but the barrier is still there. We need to figure out how to get through those things and have those open discussions. So absolutely, and educate your
Yeah, one more thing,
your
I believe-
counterparts at the legislature. Absolutely.
I agree, Fergus. You know, I mean, there's always room for improvement, but, and again, we're talking about, you know, we brought 44 out last session. Now we're dealing with it in regulations. But, you know, with how the state is working right now, almost everyone's working from home. You know, what used to take, maybe you could get them out in 6 months, we're taking 2 years to get those regs finalized. You know, that's handcuffing it as well. So, but I am concerned about, yeah, we need to, you know, when I talk to Amanda from Elko and they've got to send them to Salt Lake or Boise or even Las Vegas, and realizing that they're going to see them in 72 hours, they're going to be back on their streets. That's not a solution.
Absolutely.
Yeah.
So I think what I'm kind of hearing, Senator, is not only the organizations that are available, but what capacity they have and how that plays in for particularly Medicaid fee for service versus managed care. So that might be something that I can work with, at least in part with Sarah on, and then also looking at what other payer sources they take.
Well, yes, and capacities clearly, you know, I know we continue to cut and we talked about it, you know, we can't hire, you know, officers for public safety or even NDOT. You know, we're paying $15 an hour. How are we going to staff these facilities? So that has to be addressed first and foremost. And I think we recognize that in the legislature. But then once we do get it to the basis where we can staff it, what are we staffing? You know, we continue to close doors. Sorry, I'll get off my soapbox.
Always good, Senator. Okay, other comments? Okay, and I'll open it up for public comment then. If there's, this is where we typically open it up for public to speak. I just, you know, in the interest of time, do keep your comments short, you know, 2 to 3 minutes. We can't take action on any of those items at this point. We can move them out to agendas into the future if the board so decides, but no action can be taken on those. So at this point, I'll open it up to public comment for anybody that's joined us today.
Hi, Fergus.
I see Joan with a hand waving. Go. I thought we were just saying hi. Oh, okay.
Yeah, no, would not be that quick. You know that. Sorry, and thank you. I have a couple of things. First, I'd like to make a shout out to this board and everybody who's listening for the Crisis Summit that's being held March 7th and 8th. If you haven't heard about that, I think it's going to be phenomenal. Talking about the involuntary treatment and hold process. There will be legal CE, medical CE, RN, social work, everybody gets a CE and it's free. And so if you haven't heard about that, Valerie, maybe could you share that link to the invite? There's a lot of people already attending, like over 300. It's amazing. It's going to be a phenomenal summit. It's all virtual, half day, each of those 2 days. So I think it'd be really worth everyone's while. The second is about what Senator Goicoechea, when you were asking about, you know, could we get some of those ARPA funds? I think there's a real opportunity right now. Last interim finance committee, there were ARPA funds provided for nurse apprenticeship program reimbursement. I think if you just have a plan and you're looking at proving a concept, and transportation is that concept that it really harms all the rural areas, and especially for behavioral health. I think if you could put together something, I think there's a real opportunity to be able to prove that concept, and I would offer my help in any way that I could to help you with that. The third that I'd just like to talk about is when you talked about sharing records and those patients that come back from NAMS or SNAMS or Reno Behavioral Health back into rural communities, and we don't even have a care plan to follow. NRHP wrote a grant, a behavioral health grant, like 10 years ago. That was one of our main goals, was to get that information unsiloed. If you had cardiac surgery in Reno, you would come back and your doctor would know what your care plan was, what your meds were, what the expectations were. Behavioral health patients come back and we're going, oh gosh, we don't even know what meds you were on. The patient doesn't know, nobody knows. What is the counseling, all that. When we talked to the state, they said they were very open to sharing that. I don't know why that stopped, but Lisa Sherrick, who was in quality at NAMS at the time, is now the administrator at DPBH. I think there's some real opportunity to talk to her and say, hey, you know, this isn't happening. And the wraparound services then don't happen. It's a shame. Also, when you were talking about youth and elderly access, talk about an issue. We were on a government affairs call earlier today talking about guardianship, and not just for the elderly, but some youth who were there staying in hospitals for an extremely long period of time. And I know 4 of the hospitals in NRHP are in this region, and 3 of them I know have had the same issue, where you've had an elderly person there for days and days and days, and sometimes months, because there's no guardian. They've been dropped off there with behavioral health or dementia issues, and there's no safe discharge. And with youth, getting youth, we've had youth staying in our ERs for far too long, waiting for a behavioral health bed. So there is really an access issue. So I'm willing to help you on however that works, or whatever you need there as well. That's all I have to say. Just offering my help and adding fuel to your fire, Fergus.
Great, Joe. Thank you. It's always great to see you. And to have your help and your expertise goes far. Thank you. Other public comment.
Hi, my name is Brittany Playstead. I used to work with PACE Coalition. I am grateful to this board because I'm actually in my graduate master's program for social work and will be moving into the LCSW program here next year. So I love to follow along and see what you're doing. The other thing, and on a non-personal, more professional note, I am the patient navigator for Elko Community Health Development Foundation, and I'm on the ground with Unite Us. So if that is something you guys would like help with, please let me know, because one of the things that I can do is work with them on finding a way to include some of our behavioral health components as being necessary to our ecosystem. It's a little tricky for those nonprofit, the hospitals and entities that are not, or that are for profit and not nonprofit, but nonprofit community partners have free access to that platform. So that is something, so like Vitality has complete free access to the Unite Nevada platform, just so that, because that would be something that they're actually already talking to Vitality about currently. I am on the grounds in Elko, representative for the foundation as well as Unite Us. So if I can help with that, I would very much love to help with that. The other thing is we are working on transportation grants too, to kind of help with the necessity in Elko and other rural communities. So any collaboration, please let me know, and I would love to help if I can. Thank you.
Great, thank you. Other public comment. Okay, hearing none. Valerie, do we have additional announcements to make? I think we covered most everything.
No, I think we are good to go.
And if you would share the, as Joan mentioned, just share the information on the summit so folks can have that on their radar screen. I have conflicts that day here at the clinic, so I won't be able to make it, but
Will do.
very powerful. So folks can attend that.
Yeah, and just for to follow up with that, that's something that the Northern Board has been working on with SB 70 and previous bills as well, working on that mental health crisis hold process. So this is kind of the culmination of all that work.
So it's the work for you to know, it's work like that from other policy boards that affect all of us, same as our work affects others, as we heard from Brittany in being able to move into the ranks. So it's very good, very powerful stuff. Okay, with that, it is going on the top of the hour. And I, again, thank you all for sticking with us and being part of this, getting it refocused. We've taken some downtime. It's time to plug in and get energized, get focused. We have those meeting dates. Valerie will make sure those get sent out to us and they're on your calendars. Please try not to schedule around that. We try to keep the meetings to, maybe hour and a half, 2 hour. We went a little long today. But we like to keep them focused and moving forward so that we can stay informed and make progress. So with that, we'll call it a day and give you back a little bit of your time. Thank you, everybody.
Thank you, Mr. Chair. Hope to see you in person next time.
Yes, sir.
Thank you.